Now we are going to discuss the trauma. And in trauma, first we are going to discuss the tri-modal mortality model. Okay, so what is tri-modal mortality model for trauma? In tri-modal mortality model for trauma, immediate death, early death, late death is included and its causes are included. So what do you mean by immediate death? Imagine a patient expired at the site of accident. So patient is declared dead at the site of accident, or just after arrival into the hospital patient expires. So this is immediate death. If death occurs within hours after arrival into hospital, this is included in early death. And if death occurs days or after weeks of hospital admission, this is included in late death. Okay, so see the components here. Immediate death, we include immediate death and its causes. Early death and late death. Clear? So immediate occurs within minutes after injury. Within minutes after injury, it means sometimes the patient is declared dead. So patient is declared dead at the site of accident, or die shortly after arrival into hospital. So patient die shortly after arrival into hospital. Clear? Now what are the causes of immediate death? Sometimes these patients have irreversible brain injury, and sometimes there is massive hemorrhage because of injury of heart, aorta, lungs, liver and pelvic fracture. So what are the causes of immediate death? These patients might have irreversible brain injury, right? Or these patients might have hemorrhage. There is massive hemorrhage. And what are the sites? Massive hemorrhage because of injuries of heart, aorta, lungs, liver, pelvic fracture. Clear? Now see early death. Here we discussed that death occurs within hours of hospital admission. Okay, and what are the causes included here? These patients are generally having intracranial hemorrhage. Sometimes there is massive hemorrhage in thoracic cavity or abdominal cavity. So these patients have either massive hemothorax or hemoperitoneum. Certain patients have tension pneumothorax or cardiac tamponade, and if there is delay in diagnosis and intervention, the patient is going to die, right? So in early death, what are the causes included? First is intracranial hemorrhage. Clear? Second is internal hemorrhage, especially into which cavities? Internal hemorrhage, especially into thorax and abdomen. So there is massive hemothorax and hemoperitoneum. Or the patients might be having multiple injuries. Clear? And because of these multiple injuries, what happens? There is massive blood loss, and because of this massive blood loss, patient is going to develop what? Shock. So multiple injuries leading to massive blood loss. Simple. And certain patients have tension pneumothorax, or cardiac tamponade. Clear? So if there is delay in diagnosis and intervention, what will happen? Death will occur within hours of hospital admission. Generally, the late death, it occurs days to weeks after hospital admission. And the question which is frequently asked, that what is the most common cause of late death? It is the sepsis, right? So the most common cause of late death, this is sepsis. This is the question. Clear? And what is the other cause? Patient might die because of multi-organ failure. So there can be multi-organ failure. Clear? So this is trimodal mortality model for trauma. Now question is frequently asked related to triage. What do you mean by triage? Triage means to sort. So what is triage? The literal meaning of triage is to sort. Okay. So generally this triage is used during mass casualties. Whenever there is bomb blast, there is earthquake, we are going to apply the triage. And here, victims are prioritized on the basis of severity of injury, likelihood of survival, and urgency of care. Okay, so triage, generally we use this triage, or it is used for mass casualties. Clear? And here, the main role is it involves prioritizing victims, into categories. Okay, and it is based on severity of injury. It is based on severity of injury, likelihood of survival, and urgency of care. Clear? So how to remember? It's very easy to remember. See, the mnemonic is SLUT. Clear? So in triage, the victims are prioritized into categories based on severity of injury, likelihood of survival, urgency of care. So severity of injury, likelihood of survival, urgency of care in triage, right? So you have seen that in triage, we are using color codes for patient categorization, right? And these color codes are known as triage tags. And generally in AIMS and NEET, only this question is asked, that what are the various color codes used in the triage? And the question related to those color codes. So here you can see these are the color codes, also known as triage tags. Clear? So here color codes are used to identify patient categorization. Now see the red. Red means immediate care is required. Here, red means immediate care is required. Clear? So generally, this red tag is used for most critically injured patient, the patients who require immediate care. So this is used for most critically injured patients. Clear? And these patients require immediate care. So generally these patients have head injury. Some patients have injury to thorax or abdomen. So in these patients, generally they have head injury, or there is injury to thorax or abdomen. Thorax or abdomen. The yellow color signifies delayed care. So here the patient is less critically injured, but this patient also requires the hospital admission. So this means delayed. So here delayed care is required. Clear? And these patients are less critically injured. Clear? But see, even these patients require in-hospital treatment. So these patients require in-hospital treatment. So in-hospital treatment is required. Now the green color signifies that the patient is ambulatory. So here there is no severe life or limb threatening injuries. Green means ambulatory patient, and in this case there is no severe life or limb threatening injury. So green signifies the ambulatory patient. Clear? And here there is no life or limb threatening injury. Clear? What do you mean by limb threatening injury? Yes, sometimes patient is going to, because of trauma, especially in the lower limb, patient is going to develop compartment syndrome. So you have to relieve the pressure within time by performing fasciotomy. If you are not going to relieve it, what happens? It's a limb threatening injury. Clear? So in green, the green tag is used for ambulatory patient, and these patients are not having any life or limb threatening injury. This black is for expectant treatment. This is for expectant treatment. Expectant means here you are not supposed to do anything active because patient is already dead or moribund. So here these patients are already dead or moribund. Clear? So it is very easy to remember. Red requires the attention. Clear? So here immediate care should be provided. Why? Because these patients are most critically injured. In yellow you can provide the delayed care, but in hospital treatment is required. Green tag is used for ambulatory patient, and the black color is for dead and moribund patients. So these are triad tags. So there are three terms which are commonly used. One is ATLS, second is ACLS, and third is BLS. Clear? So what is the full form of ATLS? ATLS is Advanced Trauma Life Support. ACLS is Advanced Cardiovascular Life Support, and BLS is Basic Life Support. Okay. So ATLS, this is Advanced Trauma Life Support. Clear? And ACLS is Advanced Cardiovascular Life Support, and BLS is, this is Basic Life Support. Simple. Now see the question. There are two kinds of questions which are asked. According to ATLS protocol, we are supposed to follow ABC or CAB. So according to ATLS protocol, we are going to follow A, B, C, D, E. And what is this A, B, C, D, E? A is airway, B is breathing, C is circulation, D is disability, and E is exposure with environmental control. And if we are talking about this ACLS or BLS, here we are going to follow CAB. So you have to read the question carefully. Here CAB means circulation followed by airway followed by breathing, right? So read the question carefully in exam. So according to ATLS protocol, we are going to follow what? A, B, C, D, E. This is the sequence which we are supposed to follow. So in detail, we are going to discuss the ATLS protocol and the updates, 2018 updates. Whatever the updates are there of ATLS 2018, we are going to discuss. So according to ATLS protocol, there are two surveys. One is primary survey and one is secondary survey. So in ATLS protocol, there is primary survey and there is secondary survey. Now see, this primary survey is aimed at detecting and simultaneously treating immediately life-threatening injuries, because if intervention is not provided within the time, patient might die shortly. Clear? So what is included in this primary survey? Here it is aimed at, primary survey is aimed at first detecting and treating, what? Immediately life-threatening injuries. Immediately life-threatening injuries. Okay. So what are the components of this primary survey we discussed? A, B, C, D, E. These are the components of primary survey. So this primary survey includes A, B, C, D, E. Now see what is the full form of A, B, C, D, E. A, B, C, D, E. So A means airway maintenance with cervical spine protection. B means breathing, and in this we include ventilation and oxygenation. C means circulation with hemorrhage control. D means disability. Here we perform brief neurological examination. And E means exposure with environmental control. What do you mean by exposure with environmental control? We are going to expose the patient completely. But to prevent or to avoid hypothermia, the environment should be warm. We are using warm blankets. We are using warmers and pre-warmed IV fluids. Clear? So what are the full forms? A means airway maintenance. It's the airway maintenance with cervical spine protection. Cervical spine protection. Simple. B means breathing, and this breathing includes ventilation and oxygenation. So it includes ventilation and oxygenation. Clear? C is circulation with hemorrhage control. So circulation with hemorrhage control. D means disability, and here we perform brief neurological examination. So here we perform brief neurological examination. Clear? And E, exposure with environmental control. Environmental control. Clear? So these are A, B, C, D, E of primary survey. We will discuss in detail all these components one by one. But let's first discuss the secondary survey. Secondary survey. Now what we do in secondary survey, here we are going for systematic assessment of head to toe examination. From head to toe, we are going for systemic assessment with special emphasis on thorax, abdomen and pelvis. Right? So in secondary survey, it consists of head to toe systematic assessment, with special emphasis on which areas? Thorax, abdomen and pelvic areas. So thoracic areas, abdominal areas, pelvic areas, right? And what we do generally here, in this case, we have to perform the complete inspection of the body, and we are going to perform the repeat neurological examination. So here inspection is done. Apart from inspection, the neurological examination is performed, repeat neurological examination in secondary survey. We will discuss secondary survey also in detail. Now see, there is a tertiary survey also. This tertiary survey is not included in ATLS protocol. It's not included, but nowadays most of the centers are going to recommend the tertiary survey. Now what is this tertiary survey? See, it's the comprehensive evaluation of the patient after initial resuscitation. What is the meaning? So after 24 hours of admission, when initial resuscitation is done, then we have to again perform the comprehensive assessment of the patient. What we do in this case, we have to perform the thorough clinical examination. And depending upon the findings of thorough clinical examination, we have to go for targeted radiographic imaging. Now let's discuss with example. Imagine that after 24 hours of admission, we suspect that patient is having some kind of difficulty in breathing. And I performed the clinical examination. I found that there is resonance or dull note. So you suspect pneumothorax or hemothorax. So if you suspect some kind of pathology in thorax, you send the patient for chest x-ray. Suppose patient is having some evidence of guarding or rigidity. You suspect perforation peritonitis, or sometimes you suspect that patient might be having some kind of blunt organ injury. So if there is blunt organ injury, especially to spleen or liver, so we are going to send the patient for ultrasound or CT. So what kind of radiographic imaging is done? Targeted radiographic imaging. Okay, so see, tertiary survey. Tertiary survey, okay, not included in ATLS protocol, but still recommended by many centers. So here what we do, we perform comprehensive evaluation after initial resuscitation. After initial resuscitation, clear? And generally after how much time? So after 24 hours of hospital admission. You have to remember, after 24 hours, okay, of hospital admission. And what is included in this tertiary survey? First, we perform thorough physical examination. So here, thorough physical examination, and on the basis of the findings of physical examination, we go for targeted radiographic imaging. So targeted radiographic imaging, clear? And generally in tertiary survey, which investigations are done? So we go for chest x-ray, we go for ultrasound or CT. So all these are investigations, these investigations which are done, these are based on the findings of physical examination. Now what is the advantage? See, sometimes patient is having injury, intra-abdominal organ injury, and at the time of admission when you resuscitated the patient showed the signs of improvement, clear? And if patient is showing the signs of improvement, right, after 24 hours, if we are not sending this patient for further assessment, or we are not performing the thorough physical examination, we might miss certain intra-abdominal organ injuries. And what will happen? So what will happen if there is delay in diagnosis of life-threatening injury? It is going to increase the morbidity or mortality. So what is the biggest advantage of this tertiary survey? That it is going to decrease the delay in diagnosis of potentially life-threatening injury. This is the main advantage. So what's the main advantage of tertiary survey? That it is going to decrease the delay in diagnosis of potentially life-threatening injuries. Potentially life-threatening injuries. So this was primary survey, secondary survey and tertiary survey. Now we are going to discuss in detail the primary survey. Now see, there is one famous question which is frequently asked. Which of the following should be given first priority? And options, see the options. First, cervical spine protection. Second, airway. Third, breathing. Fourth, circulation. So out of these, which should be given the first priority? Now let me tell you one simple logic. Whenever all these options are there, your first priority should be for cervical spine protection or cervical spine immobilization. Why? Because cervical spine injury should be suspected in all patients of trauma. I'm repeating. Cervical spine injury should be suspected in all patients of trauma. So what is the first priority? You have to go for cervical spine protection, and then we are going to follow what? A, B, C, D, E. So what is primary survey? It is cervical spine protection followed by A, B, C, D, E. And you have seen the ambulance driver, CAT's ambulance driver. When CAT's ambulance driver is going to transport some patient from site of accident to his ambulance, even the patient is being transported on a hard bed, and we are going to perform the cervical spine protection. So cervical spine is protected. So first important point, the first priority is cervical spine protection. Clear? Followed by airway. Why? Because in all patients of trauma, cervical spine injury should be suspected, and this is the first step. What? Cervical spine protection or immobilization. So we are going to discuss primary survey. The first step is airway maintenance. Airway maintenance with cervical spine protection. Okay. Right. Now see, whenever any patient is brought to your emergency, how you are going to assess the patency of airway? So first thing, we have to elicit the verbal response. So what? We are going to ask the patient's name. If patient is going to tell the name, means if patient is able to speak, it means it signifies that there is adequate airway protection. And if patient is not able to speak, it means either there is obstructed airway or there is mental status depression. And if there is obstructed airway or mental status depression, both of these are indications for airway management. Clear? So see what we do. Assess the patency. So assess the patency. How we are going to assess the patency of airway? Yes, elicit the verbal response. So here we elicit the verbal response. So we ask the patient's name. Clear? If patient is able to speak, it means there is adequate airway protection. And if patient is not able to speak, patient is not able to speak. Okay. So what are the causes? Why this patient is not able to speak? Because there might be first airway obstruction, or there can be mental status depression. Why? Because of head injury. Mental status depression. And see, both of these are indications for airway management. So these are the indications for airway management. Simple. Okay. So apart from these two, what are the other indications for airway management? So certain patients have noisy breathing. If you have seen the emergency, they have noisy breathing. The patients who are having facial trauma, or whenever the GCS is less than equal to 8. So the other indications are, third, certain patients have noisy breathing. If patient is having facial trauma, right, and if the GCS is less than equal to 8, this signifies the severe head injury. Clear? So these are the 5 indications where airway management is required. Now see what is the stepwise progression in the compromised airway. So in compromised airway, what is the stepwise progression? First, you have to perform the suctioning. So you have to clear the airway by performing suctioning. So we are going to perform the suctioning of secretions, and sometimes blood is collected in the oral cavity. After that, we are supposed to open the mouth by chin lift or jaw thrust. And after this, we are supposed to insert the oropharyngeal or nasopharyngeal airway. One question which is frequently asked, that what is the definitive airway of choice? What is the definitive airway of choice in most of trauma patients? And the definitive airway of choice is oral endotracheal intubation with cuffed ET tube. So all these are important points. Have a look. Stepwise progression. in compromised airway. So first, clear the airway. So we have to clear the airway. So we perform suctioning of secretions and blood from oral cavity. Second, chin lift or jaw thrust to open the mouth. Clear? And after that, we are supposed to insert either oropharyngeal or nasopharyngeal airway. So insertion of either oropharyngeal or nasopharyngeal airway, right? And now comes the question, the definitive airway of choice in most of trauma patients. So definitive airway of choice in most of trauma patients. Clear? And this is oral endotracheal intubation with cuffed ET tube. Oral endotracheal intubation with cuffed ET tube. Cuffed endotracheal tube. Simple. Now see the ATLS 2018 update. See, initially, video laryngoscopy was not recommended for endotracheal intubation. But according to ATLS 2018 update, use of video laryngoscopy is recommended. Clear? So this is important. According to ATLS 2018 update, for intubation, what is recommended? Video laryngoscopy. So for intubation, video laryngoscopy is recommended. If you have seen the AIMS and NEET PG questions, many times these kind of questions are asked. What kind of questions? See, the patient is having facial trauma or maxillofacial injury. So if a patient is having maxillofacial injury, in this case, what is the emergency airway of choice and what is the definitive airway of choice? So whenever these patients are brought, we are supposed to establish the airway with the help of needle cricothyroidotomy. And this needle cricothyroidotomy is going to buy some time for you so that you can prepare yourself for tracheostomy. So the emergency airway of choice is needle cricothyroidotomy. And the definitive airway of choice is tracheostomy. In which patients? The patients who are having severe facial trauma or maxillofacial injuries. Clear? So the patients who are having severe maxillofacial injuries, severe maxillofacial injuries. Clear? In these patients, two questions. First, what is the emergency airway and what is the definitive airway? Clear? So emergency airway is going to buy some time for you to insert the definitive airway, and here is the needle cricothyroidotomy. This was asked many times in AIMS and NEET. Needle cricothyroidotomy. What is the advantage? Why? Because it is performed quickly. So needle cricothyroidotomy is performed quickly. And what we do here we give high flow oxygen. So here high flow oxygen is given. The tube which is inserted, what is the diameter? It is 4 to 6 mm. So the diameter of tube is 4 to 6 mm. So via this tube, high flow oxygen is given. But what is the problem? You cannot use this for prolonged period. Suppose you are using high flow oxygen via this tube, means needle cricothyroidotomy is being used for 20 to 30 minutes. So what is the problem? Patient will be having CO2 retention. So this is one of the biggest disadvantage. You cannot use it for long duration. Patient will develop CO2 retention. Second, we should not perform needle cricothyroidotomy in children less than 12 years of age. Why? Because in these children there is increased risk of subglottic stenosis. Okay, so disadvantage. So there is CO2 retention if it is used for 20 to 30 minutes. If it is used for 20 to 30 minutes. Clear? And second, it should not be used in children. Should not be used in children less than 12 years. Why? Because in these patients there is increased risk of subglottic stenosis. Simple. So these are the disadvantages. Advantage that it is going to buy some time so that you can prepare yourself for tracheostomy. So what is the definitive airway? This is tracheostomy. Right? Nowadays image based questions are asked. They will give you the image and they will ask you identify whether this is tracheostomy or this is needle cricothyroidotomy. So see how it looks like. Now see these two images. Can you see? And tell me which one is needle cricothyroidotomy and which one is tracheostomy. So this one, can you see here? This is the needle cricothyroidotomy, and here can you see there is insertion of tracheostomy tube. So this is the tracheostomy. The second step is breathing, and breathing includes ventilation and oxygenation. So the second step is breathing, and it includes ventilation and oxygenation. Okay, so first problem. Sometimes the patency of airway is intact. So there is patent airway. Despite of that, you have noticed that certain patients are having what? Dyspnea or tachypnea. Why? Because in these patients, the perfusion is affected. Why? Patient might be having hemothorax, pneumothorax, tension pneumothorax. So in this breathing, what we have to do? We have to first assess the breathing. So what we have to do? We have to visualize the chest movements. Clear? And on inspection we have to see what is the rate and depth of respiration. So visualize the chest movement, see the rate and depth of respiration, so you can easily find whether the patient is having dyspnea or tachypnea. Now imagine if you are going to find that this patient is having dyspnea or tachypnea. In these patients we have to perform the percussion and auscultation. If you perform the percussion and you notice that there is dull note, it suggests that there is hemothorax. And if there is hyperresonance or resonant note, it means there is presence of air. So there is pneumothorax. And if apart from this resonant note, you notice that there is absent breath sounds, there is distended neck veins. So these findings are pointing towards the diagnosis of what? Tension pneumothorax. Clear? So see what we do here. In this step, we are going to assess breathing. Clear? And how we are going to assess breathing? First, by visualizing the chest movements. So visualization of chest movements. Okay. We have to assess the rate and depth of respiration. Rate and depth of respiration. And what else we are supposed to perform? Percussion and auscultation. Clear? So percussion and auscultation. Okay. So we discuss if a patient is having dyspnea, tachypnea, perform the percussion and auscultation. Dull note, hemothorax, resonant note, pneumothorax or tension pneumothorax. In tension pneumothorax, patients are having dyspnea, tachypnea, what else? Absent breath sound, distended neck veins. Clear? It means if these findings are there, what we have to perform the intervention. So any patient who is having limited respiratory effort or dyspnea, all these patients require ventilation and further assessment, right? So any patient who is having limited respiratory efforts or patient is having dyspnea. Clear? In these patients, what is required? These patients require ventilation, clear, plus further assessment. Means what's the cause? Simple. Now see what are the main causes of ventilation problems. So we discussed it can be because of tension pneumothorax, it can be because of massive hemothorax, and sometimes in patients of flail chest there is massive pulmonary contusion. And the patients who are having massive pulmonary contusion, they also require what? Ventilation. Okay. So the causes of ventilation problems. Causes of ventilation problems. Clear? So first is tension pneumothorax. Tension pneumothorax. Okay. Now see the problem. So whenever some patient is brought to your emergency and you suspect that this patient is having the signs and symptoms of tension pneumothorax, so on the basis of suspicion only, you are supposed to insert a wide bore needle. Initially, it was said that the wide bore needle should be inserted in second intercostal space in mid clavicular line. But according to 2018 update of ATLS 2018 update, nowadays it is said that in children you are supposed to insert the wide bore needle in second intercostal space in mid clavicular line, but in adults you are supposed to insert the wide bore needle in fifth intercostal space slightly anterior to mid axillary line. It means it is anterior axillary line, right? And after wide bore needle insertion, what is the treatment of choice? We have to insert the intercostal drain. Where? In the triangle of safety in fifth intercostal space in anterior axillary line, right? So tension pneumothorax, it's a clinical diagnosis. So on the basis of suspicion only, you are supposed to manage the patient. Don't send the patient for radiological investigations. Otherwise, patient might die in radiology department and you might lose the patient. So it's a clinical diagnosis. On the basis of suspicion, we are supposed to insert a wide bore needle. A wide bore needle. Clear? Now where? In children, it is second intercostal space. Where? In the mid clavicular line, right? And in adults, according to ATLS updates 2018, this was asked in AIMS. Here we are going to insert the wide bore needle where? In fifth intercostal space, slightly anterior to mid axillary line. So it becomes which line? It's actually anterior axillary line. Clear? And what is the treatment of choice? The treatment of choice is ICD insertion, and where we are supposed to insert the ICD in fifth intercostal space in anterior axillary line. This is how we manage tension pneumothorax. The ATLS update of 2018 is already included in Schwartz latest edition, and this question was asked in AIMS. In AIMS, the question was asked, what is the first step in a patient who is having tension pneumothorax and the patient was adult? The wide bore needle insertion in second intercostal space or fifth intercostal space? So correct answer is fifth intercostal space. Now see what's written in the latest edition of Schwartz. So this is the 11th edition of Schwartz. You can see the page number. 11th edition of Schwartz. Now see what's written. Recent studies suggest preferred location for needle decompression may be fifth intercostal space in anterior axillary line due to body habitus. Clear? The second cause of ventilation problems, that is massive hemothorax. Clear? And the patients who are having even massive hemothorax, what is the treatment of choice? We have to go for ICD insertion in fifth intercostal space in triangle of safety. Sometimes they are going to ask you the size of chest tube used, and the size of chest tube is 28 to 32 French. So this is the size of intercostal drain or chest tube. Third problem is massive pulmonary contusion. The patients of flail chest who are having massive pulmonary contusion. Clear? And these patients require aggressive mechanical ventilation. So in these patients, aggressive mechanical ventilation is required. Okay? Okay. So in these patients, aggressive mechanical ventilation is required. So third step is C, and C means circulation with hemorrhage control. So third is circulation with hemorrhage control. Okay. So here what we are supposed to do, we are supposed to assess the circulation. And what exactly we are supposed to do, we have to look for the signs and symptoms of shock in circulation. Now see, what is the most common cause of shock in patients of trauma? It is because of bleeding or hemorrhage. So what kind of shock is seen in patients of trauma mainly? It is hypovolemic shock. Okay. So any patient who is having shock, the vitals will be unstable. And here vitals means we have to look for systolic blood pressure and pulse rate. So how we are going to assess? C. Whenever the systolic blood pressure is less than 100 mmHg and the pulse rate is more than 100 per minute. So what you are supposed to remember? 100. Systolic blood pressure less than 100 mmHg, pulse rate more than 100 per minute. These are suggestive of unstable vitals. It means patient is having shock. Any patient of shock, whenever the patient is brought to your emergency after airway and breathing, what we are supposed to do? We have to manage the shock. How we manage? First step, we have to put 2 large bore IV cannula. Preferably what kind of cannula? Green cannula is being inserted, and after insertion of cannula you are supposed to send the blood for cross match. And according to older edition of ATLS, 1 to 2 liters of warm isotonic crystalloid solution was given as a bolus. How much? 1 to 2 liters. But according to ATLS 2018 update, nowadays we give only 1 liter of warm isotonic crystalloid in adults, and in children whose weight is less than 40 kg, we give 20 ml per kg of bolus warm isotonic crystalloids. So these are important points. One by one we are going to discuss. So in circulation with hemorrhage control, we have to assess circulation, means look for signs and symptoms of shock. And what is the most common cause of shock? Most common cause of shock in patients of trauma, it's the hemorrhage or bleeding. Clear? And if it's bleeding, what is the most common type of shock in patients of trauma? And it's hypovolemic shock. Hypovolemic shock. Clear? We have to assess vitals. So we are supposed to assess the vitals, and here we assess blood pressure, systolic blood pressure and pulse rate. You have to remember the value for unstable vitals if it's less than 100 and if it's more than 100. Less than 100 mmHg, more than 100 beats per minute. Clear? So this is the definition of unstable vitals in adults you are supposed to remember. And whenever patients are having unstable vitals like this, we have to suspect the shock and we are supposed to manage the shock. So see the management. So management of shock. So here put 2 large bore IV cannula. In AIMS, this question was asked that preferably which cannula. So preferably we are supposed to insert the green cannula. You have to insert the cannula, then send the blood for cross match. Send blood for cross match. And this is the question which was asked 2 to 3 times in AIMS. According to older edition, how much fluid as a bolus? 1 to 2 liters. Fluid, what kind of? Warm isotonic crystalloids. Warm isotonic crystalloids. Okay, this was given in adults, but nowadays we are giving only 1 liter. So only 1 liter of warm isotonic crystalloid is given in adults. And what about in children? In children we give 20 ml per kg of warm isotonic crystalloid. So as a bolus in adults, nowadays we give 1 liter fluid, and in children whose body weight is less than 40 kg. So children body weight less than 40 kg, and in adults, and this is according to ATLS 2018 update. This is the question, and this question was asked in AIMS. Clear? So you are supposed to remember this is the bolus which is given. So we started the management. Simultaneously, we have to perform the rapid screening. So we have to look for the sites where life-threatening blood loss is going to occur and where it was occurred. So what are the sites where life-threatening blood loss can occur? So there is a mnemonic for this: on the floor, 4 more. On the floor means at the site of accident, external blood loss. On the floor means at the site of accident, the external blood loss, and 4 more means in thorax, in abdomen, in retroperitoneum, and fourth, because of multiple long bone fractures. So these are the 5 sites where massive hemorrhage or massive blood loss can occur. So see the 5 locations where massive blood loss can occur. Massive blood loss can occur. Clear? Mnemonic is on the floor. So on the floor means external blood loss at the site of accident. It's the external blood loss at the site of accident. Okay. And 4 more. So what are the other 4 sites? 4 more. Clear? So second is the chest or thorax. Third, it's the abdomen. Fourth, retroperitoneum. Okay, what is the cause of retroperitoneal hematoma or collection of blood in retroperitoneum? It is mainly because of pelvic fracture. It's because of pelvic fracture. And fifth, multiple long bone fractures. Multiple long bone fractures. Right? So these are the 5 sites where massive blood loss can occur. Okay. Now see, whenever we are performing the physical examination, we are looking for the sites where there is external bleeding or external hemorrhage. So if there is site from where some external bleeding is going to occur, we are supposed to apply the direct pressure or compression. So at the site of external bleeding, we are supposed to apply the pressure or compression. If the patient is having fracture, long bone fracture, we have to apply the splint. So for external hemorrhage, pressure, and for fracture, splint is used. Now coming to the investigations, that how you are going to rule out whether blood is collected in thorax or not, whether some types of or some kind of injury is there in abdomen or not, whether patient is having pelvic fracture or not. Now see, if you want to rule out whether patient is having hemothorax or not, which investigation will be done? Obviously chest x-ray, PA view. If we want to rule out pelvic fracture, which investigation will be done? Pelvic x-ray. So x-ray pelvis, AP view. And for abdomen, if we want to rule out the blunt trauma or collection of fluid, which investigation is done? And it's the FAST. So what are the investigations which are done? So the investigations done, first is chest x-ray, PA view. Second is x-ray pelvis, AP view, x-ray pelvis, AP view. And third is we perform FAST. What is the full form of FAST? It is the focused assessment with sonography for trauma. Focused assessment with sonography for trauma. Now see, there was one question in AIMS, and the question, which of the following investigation is not done in primary survey? And the fourth option in AIMS was CCT. So in primary survey, we perform chest x-ray PA view, we perform x-ray pelvis AP view, we perform FAST, but in primary survey, we don't perform CCT. So this was first question. Now see the second question. What are the two most important x-rays performed in patients of trauma? Two most important x-rays performed in the patients of trauma. So one is chest x-ray PA view. Why? Because by chest x-ray PA view, you can evaluate pneumothorax, hemothorax, tension pneumothorax, and even if patient is having perforation peritonitis, you can see the pneumoperitoneum, gas under diaphragm. Clear? And x-ray pelvis, so this is for chest related pathologies, hemothorax, pneumothorax, and perforation also, perforation peritonitis also. And x-ray pelvis, it is going to rule out pelvic fracture. So what are the two most important x-ray in any patient of trauma? Chest x-ray PA view and x-ray pelvis AP view. Now see, we started the fluid resuscitation, right? But what we evaluated, we found that despite of fluid resuscitation, patient is still having signs and symptoms of ongoing shock. So if there is no improvement despite of fluid resuscitation, it means there are two problems. What? First, we have to look for the ongoing blood loss, whether in body some kind of ongoing blood loss is going to occur or not. And second, if after fluid resuscitation patient is not going to improve, then what we are going to give? We have to give the blood transfusion. Clear? So if there is no improvement or patient is non-responding, so for non-responding patients with ongoing signs of shock, we have to manage ongoing bleeding. Clear? And start blood transfusion. Manage ongoing bleeding, start blood transfusion. Related to blood transfusion, from the last 3 years, continuously one question is being asked. And what's that protocol? The protocol is trauma transfusion protocol. And according to this trauma transfusion protocol, what should be the ratio of packed cell, plasma and platelets given to the patients of trauma? Ratio of packed cell, plasma and platelets, and it should be 1:1:1. So we follow trauma transfusion protocol. Clear? You have to remember because this is very, very important. And according to this protocol, we have to give packed cell, plasma and platelets. In which ratio? We have to give it in which ratio? 1:1:1. Now one simple question which is frequently asked, it is asked in burns patients also, trauma patients also. Since the patient is having shock and we are going to resuscitate the patient, what is the best clinical indicator of tissue perfusion? And the best clinical indicator of tissue perfusion is urine output. And see the twist in question, what is the best indicator to determine fluid requirement? Best indicator to determine fluid requirement in trauma patients, and that is CVP, central venous pressure monitoring. So two important questions. First, best indicator of tissue perfusion in trauma patients. Clear? And this is urine output. It's the urine output. Clear? Now see, best indicator to determine. So best indicator to determine fluid requirement. Determine fluid requirement, and that is CVP. So we monitor CVP. So central venous pressure monitoring. So these are two most commonly asked questions related to shock, related to trauma. You have to remember. Now see the ATLS 2018 updates related to pediatric mass transfusion protocol. ATLS 2018 updates related to pediatric mass transfusion protocol. Okay, so we discussed whenever a child is brought and in circulation after insertion of cannula, how much bolus is given? So we give 20 ml per kg bolus of warm isotonic crystalloids. After that, we have to go for blood transfusion. So in what ratio packed cell plasma and platelets are given? So we are giving 10 to 20 ml per kg of packed cells, 10 to 20 ml per kg of plasma, and 10 to 20 ml per kg of platelets. So again, what is the ratio? It's 1:1:1. Clear? So related to this pediatric mass transfusion protocol, first bolus, how much we discussed? It's 20 ml per kg of warm isotonic crystalloids are given. Clear? So there is initial 20 ml per kg bolus, and it is followed by 10 to 20 ml per kg of packed cells, 10 to 20 ml per kg of plasma, and 10 to 20 ml per kg of platelets. Clear? So again, according to pediatric mass transfusion protocol, in what ratio packed cell, plasma and platelets are given? The ratio is 1:1:1. So these are the important points. There is another update, and it's given in Bailey also, that's known as CRASH 2 trial. And we are expecting that questions will be asked related to CRASH 2 trial. So see, what is CRASH 2 trial? CRASH 2 trial. Okay, so one simple question you have seen that in surgery patients and even in gynae, after surgery, sometimes we notice that there is fresh blood coming from the drain. So we suspect that some kind of active bleeding is going on even after surgery. So to control that kind of bleeding, which drug is given in post-operative period? So we give tranexamic acid. And according to CRASH 2 trial also, which drug is given to decrease the mortality of trauma patient? Doesn't matter whether patient is having blunt trauma or penetrating trauma. So to decrease mortality because of bleeding in both blunt trauma as well as penetrating trauma, which drug is given in this trial? Yes, it's the tranexamic acid. So the drug is tranexamic acid. Clear? And it's given to which patients? The patients who are having shock or hypotension. What is the cause of shock in trauma patients bleeding? So it is given to hypotensive trauma patients. Okay, and it has been seen that it is going to decrease the mortality due to bleeding in both blunt as well as penetrating trauma. Clear? So it is going to decrease the mortality. Now, how much is the dose? So in this case, we have to give the dose 1 gram IV over 10 minutes followed by 1 gram over 8 hours. Clear? So it is given 1 gram IV over 10 minutes followed by 1 gram IV over 8 hours. Now question, in which patients we are supposed to give it? Okay, so the patient should be having significant hemorrhage. So any patient who is suspected to have significant hemorrhage and the patients who are having pulse rate more than 110 per minute and systolic blood pressure less than 110 mmHg. Clear? So in which patients it should be given? Any patient who is suspected to have significant hemorrhage, any patient of trauma suspected to have significant hemorrhage. Clear? You have to remember the parameters. Pulse rate more than 110 per minute, systolic blood pressure less than 110 mmHg. Clear? And within how many hours this tranexamic acid should be given? It should be administered within 3 hours of trauma. It should be administered within 3 hours of trauma. Now see the potential question. The first potential question is that what's the dose? 1 gram IV over 10 minutes followed by 1 gram over 8 hours. What are the indications? Patients suspected to have significant hemorrhage. Values you are supposed to remember. Pulse rate more than 110 per minute. Systolic blood pressure less than 110 mmHg. And it should be administered within 3 hours of trauma. So this is crash 2 trial. Now fourth is disability. And in this we perform brief neurological examination. So it is disability. Here we perform brief neurological examination. Okay, so you have seen in emergency that what kind of neurological examination is done. If the patient is suspected to have head injury, we perform what? GCS. And the patients in whom you are not able to calculate GCS or otherwise you are supposed to examine the pupils also. So you calculate GCS and you look for the pupils. In pupils, what we are going to assess? Size, equality, and reaction. Okay, GCS is very important. Every year in almost every exam this question is asked, so you have to remember. But see, there is an update. What's the update related to GCS? In 2014 there was slight changes in the GCS, so we are going to discuss the updated GCS and I will tell you the changes also. Okay, so see the Glasgow Coma scale which was updated in 2014. This is given in Harrison also. So what are the three parameters of GCS? First is eye opening, second is verbal response, and M is motor response. What kind of motor response? Best motor response. So three components are: first, eye opening, V is verbal response, and best motor response. Best motor response. Clear? So first question, what is the best predictor of outcome? According to GCS, what is the best predictor of outcome? Eye opening, verbal response, or best motor response? So how to remember? The best predictor of outcome is best motor response. But in exam you will not get the term best, you will just get the term motor response. So best predictor of outcome is motor response or best motor response. Okay, now see, the components here in eye opening. If the score is 4, it means there is spontaneous eye opening. So there is spontaneous eye opening. If the score is 3, it means it's eye opening to loud voice. Loud voice. So according to previous GCS, it was loud voice, but according to 2014 update, here at the place of loud voice, speech is mentioned. So 3 is eye opening to speech. Now the score 2, this is to pain. So eye opening to painful stimuli. According to previous GCS, nowadays at the place of pain, what is mentioned? Pressure. So this is the change. And obviously if the score is 1, there is no response. Simple. Now coming to verbal response. If the score is 5, patient is oriented. If the score is 4, patient is confused. Confused. And if the score is 3, according to previous GCS, inappropriate words were mentioned. But according to updated GCS, only words. So previously, inappropriate words were mentioned. Nowadays, only words. If the score is 2, incomprehensible sound was mentioned according to previous GCS, but according to 2014 GCS, only sounds. Clear? So see, score 2, incomprehensible. Incomprehensible. According to previous one, but according to new one, this is not mentioned. So here, only sounds. Clear? And if the score is 1, so there is no response. Okay. Now coming to motor response. If the score is 6, it means patient obeys command. So score 6. Here, patient obeys command. Whatever you are going to say, he is going to follow. If the score is 5, patient is going to localize pain. So localizes pain. Score 4. Here there is normal flexion. Normal flexion means whenever we are going to apply the painful stimuli, there is withdrawal to pain. So there is normal flexion means there is withdrawal to pain. Clear? If the score is 3, there is abnormal flexion. Abnormal flexion. Clear? According to previous GCS, abnormal flexion posturing was mentioned, but according to 2014 updated GCS, only abnormal flexion. If the score is 2, here abnormal extension. So here extension. So what kind of posture? Posture extension. And if the score is 1, there is no response. There is no response. Okay. Now how to remember? See, eye opening is easy because 4 is spontaneous, 3 to speech, 2 to pressure, and 1 is no response. How to remember the verbal response and best motor response? See here, one confused word sounds nowhere. So how to remember? For verbal response, the mnemonic is 1 confused word sounds nowhere. Clear? So 1 means oriented, confused words sounds nowhere means no response. So here it's 5 4 3 2 1. And how to remember the best motor response? Here the mnemonic is obey localities. Obey localities with flexion and extension. Flexion and extension. So can you see? obey localities with flexion and extension. So obeys command localizes pain, withdrawal to pain, there is abnormal flexion, extension. So here you can see the score. This is 6, this is 5, this is 4, this is 3, this is 2, and 1 is no response. Clear? So this is very easy to remember. Now this is EVM, electronic voting machine. So what is the maximum score, GCS score? So you saw E4, V5 and M6. So it is 15. And what is the minimum score? It's E1, V1, M1. So 3. So generally Glasgow Coma scale, it varies from 3 to 15. And we discussed what is the best predictor of outcome. It is the best motor response. Generally in question best word is not mentioned, so it is the motor response. Second question, depending upon the GCS score, how we are going to divide head injury into mild, moderate and severe. So according to GCS, head injury is divided into mild, moderate and severe. Clear? So how much is the score in mild? It is 13 to 15. And how much is the score in moderate head injury? It's 9 to 12. And whenever the score is less than equal to 8, it's the severe head injury. Okay, so you have seen a new kind of question which is being asked in AIIMS from last 2 to 3 years. It is related to the component or element which cannot be tested. Now imagine there is a patient of trauma who is having tracheostomy, and this patient is brought to your emergency. Clear? So suppose the patient is having spontaneous eye opening. So how much is the score? Eye opening spontaneous E4. Here the verbal response cannot be assessed, and if patient obeys command, so it is M6. Since this verbal response cannot be assessed, so it cannot be tested, so this is not testable. So how we are going to depict? Here we are going to mention that this is not testable, and since it is not testable, we are going to write it like V and T. So for that element we are going to write what? NT, not testable. Now see the important points related to non-testable components or element. So any element that cannot be tested should be marked as NT, and that is not testable. Initially it was said that we are supposed to assign 1 point to this non-testable element, but nowadays it is no longer recommended to assign 1 point to non-testable element. Let's discuss it with one example. Imagine if a patient of trauma is brought to your emergency. That patient was having tracheostomy at the time of presentation. This patient was having spontaneous eye opening. This patient was not able to move his left upper limb, but patient was localizing pain in right upper limb. Okay, so patient was having spontaneous eye opening. So what is E? It is 4. Patient was having tracheostomy, so the verbal response is not testable, so we are going to mention NT for verbal response. And see the M. Left upper limb, this patient is not able to move the left upper limb. Why? Sometimes patients are having fracture. That's why in motor response the term is best motor response. So in right upper limb patient is going to localize the pain. So what is the best motor response? It is M5. So how much is the score? It is 9 VNT. So we are supposed to write it like this, 9 VNT. So if in exam this option is there, mark it. But suppose in exam the options are 8, 9, 10, 11. This presentation and the question is asked that calculate the GCS. And if the options are 8, 9, 10, 11, what you will mark? You will mark 9. Why? Because it is no longer recommended to assign 1 point to non-testable elements. So these kind of questions are asked frequently. You have to be very careful when you are reading the questions and reading the options. Now see another potential question. GCSP. We discussed GCS. So what is GCSP? Okay. So in this GCSP, what is the meaning of P? This is pupil reactivity score. Pupil reactivity score. Okay. So this pupil reactivity score means the number of non-reactive pupils. Okay. Now see the scoring. So this is the number of non-reactive pupils. Okay. So imagine if both pupils are non-reactive, how much is the score? 2. If only one pupil is non-reactive, how much is score? 1. And if neither pupil is non-reactive, how much is the score? Score 0. It means the score of pupil reactivity score PRS, it varies from 0 to 2. Simple. So what is the score of GCS? We discussed it is 3 to 15. So the GCS score is maximum is 15, minimum is 3. And if we want to calculate GCSP, yes, so maximum GCSP is 15 minus 0, that's 15, and minimum GCSP is 1. So if you are going to calculate GCSP, means GCS minus pupil reactivity score, it varies from 1 to 15. Clear? So GCSP means Glasgow Coma Scale minus pupil reactivity score. So maximum is 15 minus 0, that's 15. Minimum is 3 minus 2, that's 1. So this is one update, it's a potential question. There is a second update related to GCS, and that's known as GCS PACT. And it's very easy to remember, GCS PACT, because it's like a mnemonic. So see what are the components. Here the components are GCS. P means pupils, A means age, and CT means CT findings. Clear? So in GCS PACT, the components are GCS, pupils, age, and CT findings. These are very, very important. Every year at least one question is asked related to this particular topic. Now the fifth component of primary survey, and that is exposure with environmental control. Exposure with environmental control. Clear? So here all clothings of the patient should be removed. So patient should be completely exposed so that we are going to perform the examination. But the problem, whenever the patient is exposed, there are increased risk of hypothermia, right? So what we have to obtain, the core body temperature. So measure the core body temperature. Second, we have to avoid hypothermia. So first, exposure means the patient should be exposed. The clothings are removed for adequate examination. Core body temperature should be obtained. And we have to prevent hypothermia with the help of environmental control. So how we are going to prevent hypothermia? First, we are supposed to use warm blankets. So use warm blankets. We use body warmers. We use blowers so that the temperature of room is increased. So increase room temperature. And we give pre-warmed IV fluids. So what kind of fluids? Pre-warmed IV fluids are given. Clear? So these are 5 components of primary survey: A, B, C, D, E. Now according to ATLS 2018 updates, what are the life-threatening injuries in primary survey? So according to ATLS 2018 updates, life-threatening injuries during primary survey. Okay, so see the injuries related to airway, related to breathing, and related to circulation. So first, airway related. Second, breathing related. And third is circulation related. Okay, so see the life threatening injuries. Airway related, if the patient is having airway obstruction or patient is having tracheobronchial injuries, and this was also asked in AIMS. Tracheobronchial injuries. Breathing related we discussed. Most important, tension pneumothorax. Tension pneumothorax. Clear? Or sometimes patient is having open pneumothorax that can also kill the patient. So it's also life threatening if adequate intervention is not done. Circulation related, massive hemothorax. Sometimes patients are having cardiac tamponade, or traumatic cardiac arrest or circulatory arrest. So traumatic circulatory arrest. Clear? So these are the life-threatening injuries during primary survey. Now see the secondary survey. In secondary survey, we are going to obtain ample history from the patient. If patient is able to give the history. If patient is not able to give the history, then we are taking this ample history from relatives. So see what's this ample history in secondary survey. So first we try to get this history. Ample history. Okay. Now see what's the full form of this ample history. So here ample history, A means allergies, M means medications, P means past illness or history of pregnancy, L means last meal, and E events related to injury. If there is some eyewitness or the person who was the accident, that person can describe. So this is ample history in secondary survey. We discussed that what we do in secondary survey, systematic assessment from head to toe, and we are going to perform the complete physical examination and we perform repeat neurological examination. So there are 7 steps, 7 sequential steps which are followed in secondary survey. First, we are supposed to examine head and face. Second step, examination of neck. Third step, examination of chest. Fourth, examination of abdomen. Fifth, examination of back. Sixth, examination of extremities. And the 7th step is neurological examination. So see the steps of secondary survey. Steps of secondary survey. Clear? So first step is the examination of head and face. Head and face. Clear? So what we are supposed to look for in head and face? In head, skull fracture, and in face, laceration. So we want to rule out fracture and laceration. Clear? Step 2, examination of neck. And in the neck, what we are supposed to rule out neck injuries. So in neck, rule out neck injuries. Okay. After that, step 3. In step 3, we are supposed to examine the chest. What we want to rule out here? Here we want to rule out the rib fracture. So examination of chest to rule out rib fracture. Okay. The 4th step is examination of abdomen. This is very, very important, frequently asked. Okay. So in abdominal examination, what we are going to examine, first we are supposed to look for the external signs of injury like bruising, some kind, the patterned bruising of stick or tires of vehicle. We have to rule out intra-abdominal organ injury, so we have to look for tenderness, guarding rigidity, right? In patients, during this phase, we are supposed to insert the nasogastric tube. And if a patient is having facial trauma, in these patients, we have to insert orogastric tube. Second, you have to examine the meatus. If there is no blood at meatus, then only we are supposed to insert the Foley's catheter. So Foley's catheterization is done if there is no blood at meatus. Why? Because if blood is at the meatus, it suggests the injury of urethra. So presence of meatus is highly suggestive of urethral injury. So if there is no blood at meatus, we perform the Foley's catheterization. So in abdominal examination, look for bruising, means external signs of injury, internal signs of injury like abdominal tenderness. Insert nasogastric tube. This was the question which was asked in AIMS. If there is facial trauma, so in patients of facial trauma, we have to insert orogastric tube. Okay. Foley's catheterization. So insert Foley's if no blood at meatus. If there is no blood at meatus. Okay. So this is the fourth step. The fifth step, which is frequently asked in exam, and that is examination of back. This is also known as log roll. Now see the problem. Majority of patients are in the supine position. Trauma patients are lying in the supine position. And if you are supposed to examine the back, you have to roll the patients like log in one go, right? So how many people are required for examination of back or log roll? 5 people. Why? One person will be supporting the head, 3 people will be supporting the body, and one person will be standing behind the back of patient to perform the examination. So 2 important questions. Ideal number of people required for log roll, 5, and the minimum number of people required for log roll is 4. So fifth step, it's the examination of back. Clear? And this is also known as log roll. So how many people? Ideal number of people required for log roll, 5. Minimum number of people required for log roll, 4. So these 5 people, what is their job? 1 person for supporting head, 3 persons for supporting body, and 1 person to perform the examination. Clear? So whenever we are doing the examination of back, during this stage only we perform the digital rectal examination. So during examination of back only, digital rectal examination is done. Questions which are asked. Log rule is done in the examination of back. Ideal number of people required for log rule, 5. Minimum number of people required are 4. Now the step 6. Here we are going to examine the extremities. What we want to look for in extremities, we have to rule out the fracture. And if we have to rule out the fractures, we are looking for tenderness, crepitation, deformity, and some kind of abnormal movement. So here look for tenderness, crepitus, deformity, and abnormal movement. Clear? So abnormal movement. So what we want to rule out here, we want to rule out the fracture. 6th step. And what is the 7th step? 7th step is neurological examination. Clear? So here we perform the neurological examination. And what we do here, we did GCS in disability. 4th step, that is brief neurological examination. Here we are going to repeat GCS to see whether there is improvement or there is deterioration. So here we are going to assess, repeat GCS. Second, re-evaluate pupils, re-evaluate Okay, we are looking for localizing or lateralizing signs, and we are looking for signs of spinal cord injury. So look for localizing or lateralizing signs, and we look for signs of spinal cord injury. Clear? So these are 7 steps of secondary survey. All these steps are followed in this sequence only. So first head and face, second is neck, third is chest, 4 is abdomen, 5 is back, 6 is extremities, and 7th step is neurological examination. Now see the one-liner questions related to trauma scoring system. It's very important, especially asked in NEET PG names. So trauma scoring systems. There are 3 trauma scoring systems which are frequently asked. First is revised trauma score. Revised trauma score. Second is trauma and injury severity score. And third is mangled extremity severity score. Okay, one by one we are going to discuss. This is revised trauma score. Revised trauma score. Okay, what are the components of revised trauma score? First, GCS, Glasgow Coma Scale. Second, blood pressure. What kind of blood pressure? Systolic. And third is the respiratory rate. Clear? GCS, blood pressure, respiratory rate. So how to remember? It's very easy to remember. GB road. So the mnemonic is GB road. Don't go to this road. TRIS, the full form is trauma and injury severity score. So this is trauma and injury severity score. Clear? So what are the components? First component is injury severity score, and the mnemonic is RAM. So it is injury severity score plus RAM. So here R means revised trauma score, A means age, and M means mechanism. Mechanism means whether there is blunt trauma or penetrating trauma. So how to remember? Injury severity score plus RAM. Revised trauma score, age, mechanism. This is mangled extremities severity score. Mangled extremity severity score. Okay, and how to remember? There is another mnemonic. So mnemonic is ELISA. It is ELISA. Okay, so E is energy. So this is energy. LI, that's limb ischemia. Okay, S, shock, and age. Clear? All these are important, and you can see the scoring systems are having 3 or 4 parameters. So these are ideal for MCQs, and that's why these are frequently asked. Since mnemonic is there, you can easily remember and you can mark the correct answer.